Welcome to the Eating Disorder Recovery Podcast.
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 Welcome to the Eating Disorder Recovery Podcast with me, Dr. Janine Anderson. Heads up, this show may contain adult language and may mention specific foods. If you find either of those to be too triggering, I trust you to take care of yourself and do what you need to do. This podcast is sponsored by Ipono Maui and ED Care. Ipono Maui is led by internationally renowned expert on eating disorders, Dr. Anita Johnston. Located in a home-like oceanfront facility in beautiful Maui, Hawaii, Ipono offers residential, partial hospitalization, and intensive outpatient treatment for eating disorders. Visit iponomaui.com, spelled AIPONOMAUI, to learn more. ED Care has provided PHP, IOP, and outpatient treatment for all genders 18 and over since 2001. CAMSA, which stands for Connection, Acceptance, Mindfulness, Sense of Self, and Action, is ED Care's mindfulness-based treatment approach and is incorporated into each individualized treatment plan. Facilities are located in Denver, Colorado Springs, and Kansas City, and all treatment is supported by master's level clinicians or higher. ED Care offers 4 specialty tracks for binge eating disorder, elite athletes, substance use, and trauma. And the Connections House, an affordable supportive housing component, adds an extra layer of supervised support. Visit eatingdisorder.care or call 866-771-0861. Hello, friends. At long last, I am back. I missed you so much, and I am very sorry it took so long to get things up and running again. The delay was due to several things changing on the production side of the podcast, which I'm not that good at, and I hire people to do the technical part of things, thank God. So that's mainly what the delay was about, and it was also about trying to coordinate schedules with the different guests who are joining us on this season. So again, I'm really sorry about that, and it feels so good to be back with you guys. The new structure of the podcast is that I'll release episodes in 10 episode seasons. So each season will have 10 episodes, and I'll probably take a little break in between, though I don't intend to take this long of a break ever again. Trust me, that pained me as much as it may have pained you. One of my biggest pet peeves in life is missing a deadline, and I just kept missing my own deadline, and other people were missing my deadline. Oh my gosh, tested my patience right there. So right now, we're planning to release new episodes every other week still. And again, like I said, I hope I never have this long of a chunk of a break. So thank you for your patience and hanging in there. I am not going anywhere. It just took me a little bit longer to get this season 2 up and going versus what I thought it would be like. Other news, over the break, I became a certified eating disorder specialist. This is a special designation provided through the International Association of Eating Disorder Professionals. So I'm really excited and honored to have CEDS behind my name now. Another new thing that's happened is now I'm offering one-on-one recovery coaching and consulting. So if you're out there listening somewhere across the country or maybe across the globe, we could still potentially work together. We could talk about what that would look like for you to have me one-on-one individually coach you and help you out with your recovery. I picture that looking like you and I having one-on-one time to talk and walk through any of the material that I talk about on the pod or in my book. I mean, I've been treating eating disorders this will be 9 years in addition to my own recovery process. So I feel like I've got a pretty good grip on understanding them. Okay, speaking of my book, yes, it is coming out this fall. It is. As of this recording, which I'm recording this the end of January, as of this recording, I don't have a firm launch date, but it will be in the fall of this year, 2017, in case you're listening to this episode in the future. I will absolutely let you know once I set a firm date. Like the second I know that, I'm going to put it on the very next podcast episode. The book will be available through Amazon and most likely we'll do a pre-sale so you can order a copy early. That's also not completely solid yet, but I will let you know. The best way to keep in touch with me online for announcements is to, especially about the book, is to follow me on Facebook. So my Facebook page is facebook.com/Dr. Anderson author. That's DrAnderson author. So please follow me there. And if you're finding the podcast helpful, do me a favor and leave us a review on iTunes. This really helps new listeners to find the show. Also, if you know someone who might benefit from listening to the show, please just pass the podcast info along. Just tell them to search Eating Disorder Recovery Podcast on iTunes or YouTube, or you could have them check out the podcast online at www.eatingdisorderrecoverypodcast.com. Make sure you subscribe to the podcast on iTunes and YouTube. And then also, if you haven't signed up for my email list, I would encourage you to do that because we have a whole marketing plan for this year of being able to give you guys free pieces of my book and kind of just check in on what's happening with the podcast, who are the future guests that are coming up, that sort of thing. You can also do that at eatingdisorderrecoverypodcast.com. A little pop-up box will come up and you can enter your email there. You get to, we won't spam you. We won't give away your email address or anything like that. So one last note, if you are a treatment provider, I'll be at the IADEP annual symposium in Las Vegas. It's actually in Henderson, Nevada. And the podcast will have a booth. So come make sure to stop by and say hi. I would love to meet you all, meet my colleagues in the field. And if you need any materials to give to your clients to help them access the podcast, we can send those to you. You can also, if we meet up at IADEP, I'm going to bring a bunch of stuff with me there. If you want materials to give to your clients, like, hey, check out this podcast. It might be really helpful for you in between sessions. You can shoot us an email. The email for the podcast is podcast@eatingdisorderrecoverypodcast.com. So without further ado, let's get to the good stuff with internationally recognized internal medicine physician, Dr. Jennifer Gaudiani. Our guest today is Dr. Jennifer Gaudiani. She is the founder and medical director of the Gaudiani Clinic. She's board certified in internal medicine. She completed her undergraduate degree at Harvard, medical school at Boston University School of Medicine, and her internal medicine residency and chief residency at Yale. From 2008 to 2016, she was one of the leaders of the Acute Center for Eating Disorders at Denver Health, the nation's top medical stabilization center for adults with eating disorders who are too medically compromised to receive care in a mental health setting. She left as Acute's medical director to found the Gaudiani Clinic, which provides superb outpatient medical care to patients with eating disorders and disordered eating of all shapes and sizes. Through a collaborative, communicative, and multidisciplinary approach, the clinic cares for the whole person in the context of their values. She has lectured nationally and internationally, is widely published in the scientific literature as well as on blogs, and sits on the board of IADEP, the International Association of Eating Disorder Professionals, as the only internist. Dr. Gaudiani is one of the very few outpatient internists in the United States who carries the Certified Eating Disorder Specialist designation. It is no exaggeration to say that Dr. G is truly a superstar in the field of eating disorder treatment. Dr. G, welcome. Thank you so much for taking the time to join us today.
Janine, thank you so much for having me.
Oh, we're honored. I mean, really, you are an absolute rock star, just the top doc. I'm so happy to have you here to talk about the medical complications with eating disorders and the role of physicians in eating disorder treatment. So I thought that just in case people don't have very much information about your background or what acute is versus what outpatient is, I was hoping you would tell us a little bit about kind of your career path and how you got into this. And we can talk about acute and then talk a little bit more about your current role at the Gaudiani Clinic.
Thank you. I would love to start there. So my journey begins with the fact that I'm the oldest of three sisters. And so many of us contextualize our stories in our family narrative. when I was in medical school, one of my sisters developed an eating disorder. And I only knew at the time enough to say, I love you unconditionally, and my love isn't going to be enough. And I want you to get a terrific team to help you get over this. And she did over the course of years, and she has been in recovery for a long time. She has been recovered, I should say.
Wow, that's amazing.
I also had a god sister who developed type 1 diabetes when she was 7 and began misusing her insulin to lose weight at age 12. And I watched her struggle through care systems that, quite frankly, involved an older white physician not listening to what she had to say and what her fears were. And every time she would say, honestly, frankly, I'm afraid of gaining weight if I use my insulin correctly, some head of a department of endocrinology would pat her on the head and say, let's first get those blood sugars under control.
Oh, gosh.
And, she has had a much harder time. And so as I went through my medical school training, I had a profound sense that regardless of what specialty I chose, I wanted to be able to sit with patients and hear their whole story and understand from them what language they spoke, what did they care about, so that they could bring to me their knowledge of themselves deeply, and I could bring to them my knowledge of medicine, and maybe through a collaborative effort, I could help them make their chronic medical conditions more bearable and more manageable. And I almost went into OBGYN because I love women's medicine, but I realized ultimately that I'm the classic internal medicine nerd who likes being involved with everything. And so I did my internal medicine training and chose not to subspecialize because I really do love the whole person. And when my husband and I moved out to Denver 9 years ago now, I joined Denver Health because it was the inner city teaching hospital of the University of Colorado. I love teaching. I speak Spanish, so I really enjoyed that population. But by great fortune, a year into my employment, Dr. Philip Mailer, whom many know as the world expert in the medical complications of eating disorders, wrote an email to my division in the hospital saying, does anyone want to help me start in a new form the nation's only multidisciplinary medical stabilization center for adults whose eating disorders have gotten too critical to receive good care anywhere else. And I volunteered, and I had the greatest fortune to be able to grow up as a physician within acute and became its medical director. And in the course of working with a truly collaborative team of wonderful experts, nurses, dietitians, physical therapists, occupational therapists, speech language pathologists, psychologists, MDs, I really broadened and deepened my knowledge of this disorder and of its medical complications. And it turns out there just aren't that many internists who know eating disorders. And so ultimately, at the end of an amazing 8-year stretch there, I decided that what I was missing most was to have lasting relationships with patients over time. I would fall in love with them for their 2-week stay at acute during their worst days ever. And then I wouldn't necessarily hear how things went. And so I fulfilled a long-time dream of opening an outpatient clinic, and the Gaudiani Clinic opened in September and really aims to be a totally unique care setting within the Front Range, but also nationally, because I'm licensed in a bunch of other states to be able to establish care here and then actually provide telemedicine care to patients in various states around the country. And sorry, go ahead.
Oh, so even if patients are not in Colorado and they're listening to this podcast and they're interested in learning more about you or your clinic, they can reach out to you and see if that is an option?
I hope they would.
That's awesome.
Yeah, and I think this clinic to me is feeling so exciting and fresh to bring my passion for the medical complications of eating disorders to patients, to their families, and to meet them where they are, taking care of patients 15 and up, of all genders, of all shapes and sizes, whether they have a true diagnosed current eating disorder or they're recovered from one, or they've always had eating issues and they've got a really sensitive body that's tightly tied to their emotional state. These are the patients that unfortunately are getting failed by current medical outpatient systems, and their loving, wonderful therapists and dietitians are kind of stuck solo with them in the community saying, are they safe to continue care outpatient? I don't have a doctor I trust to send them to.
Yeah.
Because the doctor may make some unwitting but really triggering comment like, oh, you're so thin. How do you do it? Or, yeah, I'm a real runner too. And,
I can definitely attest to that as a psychologist in the community who has clients who have to just generally go to whoever their primary care is, who is usually not trained at all in eating disorders, and just kind of how, unfortunately, because physicians are not trained in that it can be really difficult on our clients who do have eating disorders. Can you tell us a little bit more about, because just in case, people aren't geeking out like us as professionals, like why there is kind of that gap in the care between what our patients need and when they go to their primary care, their OB, their internist, like why that physician is not likely to understand eating disorders?
Absolutely. The vast majority of physicians want to spend lots of time with patients and really want to be knowledgeable about what patients bring. Unfortunately, I got 0 hours of training in eating disorders during my entire medical training.
Wow.
Nothing. And studies are showing that the vast majority of medical professionals get at most a couple hours and otherwise get nothing. And so, I think what many people don't know, although folks with eating disorders know it and live it, is that there are a lot of medical problems that arise from malnutrition, from rapid weight loss, even when people's bodies are still in a larger size, from severe underweight, from purging. And they're sort of dealing with those things alone, where the eating disorder voice says, you're not sick enough for treatment. What makes you think you are sick? Look, you can still be a great student. You can be a great professional. You're still managing. You're not sick enough.
Right.
And then they go to their doctor, and it's usually a pretty rushed affair. And they may not have had a chance to really be known as a whole human by every member of the clinic. And then they start to tell their story, and it's like 8 minutes later, and maybe a GI referral later.
Right.
And someone saying, well, your labs are fine and your tests are fine. So I don't know why your stomach hurts. I guess you just have IBS. You're just going to have to deal with it. Or they say, well, sure, your heart rate is 35, but you told me you're a runner. So that's just fine, right? You're a nice, thin runner. And like the patient in his heart says, I kind of wanted somebody in authority to tell me, it's all right, babe, put down the reins.
Right.
You've done enough. This isn't good for you. And instead they hear, you're fine.
Yep.
That makes recovery so hard, right?
Oh, totally. And that's unfortunately, I think the most common one I've heard in practice is, but my labs are fine. So I just think that that's a really complicated one to work with, definitely as a psychologist. And I'm, of course, as a physician, I would imagine. Can you talk to us a little bit more in detail about what some of those complications are that commonly come up from having an eating disorder or subclinical eating disorder that maybe most physicians aren't picking up on, but we still need to take care of?
Yeah, I would love to. Let's break it up in a couple of different categories.
Yeah,
Let's
definitely.
talk about pure food restriction. And this could be in someone with anorexia nervosa who is underweight, or it could be somebody who started out intending to eat healthily and ended up restricting so hard because of fears of contaminants or of other stuff that they started to lose weight and maybe in any body size. When the body gets starved, what I like to call, and I'm going to use the gendered word here, your cave girl brain.
Yeah, that's all right.
What she thinks is, oh boy, we're in a famine. And our bodies are great at adjusting to famine conditions because that's how we survived as a species. And what your body does is slows down the metabolism so radically in order to survive the famine. So a lot of things emerge from that. One, people feel cold all the time. They might especially have cold hands and feet, because if anyone's ever tried to save on the heating bill in the winter by shutting off a room in the apartment or in the house that's not used, that's what Mother Nature does with our hands and feet. She says, I'm not going to give hot, calorie-enriched blood to the hands and feet. Those aren't necessary for life.
Yeah.
And so your circulation decreases and your hands and feet get cold. Your digestion slows way down. Many people who restrict will find that even if they want to eat more, as they get scared of what's going on, they find that a few bites in, they feel full and they think, gosh, everyone talks about intuitive eating. My body is telling me I'm full. That's not the right kind of intuition as your body is struggling to stay alive. That's called gastroparesis. And it's a slowing of the food's release from the stomach because your body literally doesn't want to spend a calorie on a normal wriggle of your intestines and stomach.
Wow.
And that's why constipation is really common as well, slowing the metabolism down. People will also find that their heart rates get really low. And that may be in the setting of being a fine athlete. But the fact is that when you're starved, just like a bear in hibernation in winter, your heart rate slows because your body doesn't want to use an extra calorie to beat the heart so many times. And so all of these things, some of them measurable, some of them not, reflect a metabolism that slows profoundly. In addition, there can be organ systems that fail simply by virtue of not having enough calories. For instance, your liver tests can start to rise. That's the AST and ALT. Those are measures of your liver function that when they rise, they're a marker of a liver that's starving and consuming itself. In fact, when liver tests rise to 3 times normal, that's actually in a study that I performed while at Acute with my colleagues, showed that that's an independent risk of low blood sugar. And that probably brings me to one of the most important complications of nutritional debilitation and underweight or rapid weight loss. Low blood sugar, I believe, is the killer in anorexia nervosa.
What makes you say that?
A lot of people talk about the heart in anorexia because, of course, people's heart rates can go very slow at rest and very rapidly when they move. And this isn't even with the complications of purging, which causes electrolyte problems and can impact the heart. In anorexia, well, let me take a step back. In people who are well-nourished, in between meals, our liver builds us glucose and puts it into our bloodstream, so that we always have enough blood sugar for our brain and our heart and our cells to run on. But when your liver gets depleted and when you don't have any gas left in the tank, your liver can't build you blood sugar. And in between meals, the longest period of which is often overnight, your blood sugar can fall dangerously. And many patients with anorexia or with severe weight loss don't have symptoms. They don't feel shaky and rigid and irritable and weak, at least not more than usual, and there's no warning sign.
Wow.
But when your blood sugar gets low enough, your brain and your heart will stop. And that is the reason so many people who perish from this disease that has the highest death rate of any mental illness are found down at 5 in the morning, at 8 in the morning by a loved one who comes in to try to wake them up and cannot.
Yeah, I think that that's just really worth restating, is that anorexia nervosa has the highest mortality rate of any mental illness.
It's really striking. The death rates are 6 to 10 times that of age-matched peers.
Wow.
So I don't care what your blood tests look like. I don't care what your measurements are. If you've been diagnosed with anorexia nervosa, you have a 600 to 1,000% increased risk of death.
Oh, it's heavy to hear that.
It is. It is. And so much of the eating disorder voice tries to tell my patients, you're fine.
Yeah, no big deal. Keep going.
Yeah, you're not sick enough. In fact, go harder tomorrow.
Mm-hmm.
And these are the messages that I can bring to my patients when they come in to see me. It's not to be all gloom and doom because, there's no intellectual deficit in understanding what are the consequences of this, but to speak to the heart and to help try to keep giving answers back to that eating disorder voice when it's being so mean.
Right.
As we talk about other medical complications, for instance, the ones that emerge from purging, electrolyte problems are one of the biggest ones. Low potassium can cause the heart to stop. In addition, when patients purge a lot, and this is probably one of the things that I most enjoy talking about with patients, their body, we'll go back to their cave girl brain, gets the message that they must be dying of dehydration in the desert. And that if they're so lucky as to come upon an oasis where they have salt and water, they'd better have increased production of any hormone that'll keep them from peeing away those life-saving resources. Mm-hmm. And fascinatingly, that's just what people's bodies do who purge by vomiting, by laxative abuse, or by diuretics. The process is called pseudo-Bartter syndrome. Welcome to Nerd World.
Right.
And what happens is your adrenal glands overproduce a hormone called aldosterone. And in the setting of high aldosterone, your body does two important things. And this pretty much affects anyone who's purging. One, when you do take in salt and water, your body holds on to it rather than letting you pee it away normally. And two, your body pees away potassium, which is the last thing you want to lose from your bloodstream because it's already a low level. And so what patients who purge find is that when they stop purging, they're ready to make that behavioral change, they find to their dismay that the scale, if they're so unfortunate as to be weighing regularly, rockets up. And they feel differences in their body almost immediately. And the reason is because their pseudo-Bartter syndrome hasn't been properly medically managed. It's easy to manage. It's not hard. You have to have a physician who's willing to go on that journey with you. You have to be gentle on your fluid intake while you're starting the purge detoxification process. That is, you're no longer purging. And you have to take for about 2 or 3 weeks a medication that blocks the aldosterone production. Mm-hmm. And that medicine is spironolactone. It's an old-fashioned diuretic that's not abusable. It's not that strong, but it's designed to block aldosterone. Mm-hmm. And when patients who purge and are ready to start these care processes, they come through and they go, I never knew this was possible. I always thought my body was just betraying me, that I had messed it up permanently. And it's so joyful for me to be able to say, nope, you're still amazing. We can get you through this. It's still going to be hard, but we can optimize this medically.
Yeah, I just can imagine and have so much empathy for my clients who are in that situation where, they're discontinuing their purging, and then they have to deal with this raging edema from the pseudo-Barters. Yes. And I've had so many people have that missed because I've had multiple clients who have had to go to the ER because they feel dehydrated. And then the ER, of course, because they don't know, pumps them full of a bunch of fluids. And then they get this ridiculous water retention, which of course triggers them, into oblivion.
Wow.
And it's so unfortunate to just see the gap and where a specialist would be so helpful because you know what's going on there.
Yeah. And, I think that if patients are able to bring either a blog I write or a medical article to their physician and say, hey, listen, I'm not making this up. This is not part of my eating disorder. This is physiologic. Will you help me with this? My hope is that at least some of the doctors will say, yeah, I want to do my best by you. I just didn't know about this. Thanks for letting me know about it.
Definitely. I didn't know if there were more things about the medical complications that you were wanting to cover, or I have another question lined up for you already too.
I feel like we gave a taste of the medical complications, and
Yeah.
I could easily talk for 3 hours about medical complications, but I do not want to bore your listeners. So why don't we continue on with your next question?
I could easily listen for 3 hours, but I will, take one for the audience and go ahead and move on. But I wanted to ask you to talk a little bit about what the role of the physician is in an outpatient treatment team. So I think it's very common for people who are really working their recovery to have a therapist or a psychologist on their treatment team, to have a dietitian outpatient on their treatment team. Sometimes there's a psychiatrist on their treatment team. Talk about the role specifically just of the outpatient physician.
Thank you. That's a great question. Right now, I think the state of eating disorder care, where the majority of patients receive it in the outpatient setting, is with the dietitian, the therapist, and the psychiatrist, as you said. What this does, though, is puts an undue burden on the eating disorder professionals on the mental health and dietary side who are taking care of the patient. It means that the psychologist, the therapist, is the one being asked to interpret labs and to say, is this wonderful person still safe for outpatient care? Do they need to step up a level of care? I don't know, because we just got to the heart of what needs to be discussed. And as a result of really getting to the scary stuff, behaviors are escalating. And the psychologist, the therapist is being asked, the dietitian is being asked, hey, interpret these labs. Is she still safe? Is it okay? That's not fair. That's out of scope of practice. And it leaves the patient in a medically risky place. But it's not just a medically risky place. It risks the whole patient's outpatient world, because the vast majority of people want to stay in their communities. They want to stay in their partnerships, in their school, in their job, as a parent, as a caretaker, as a sibling. And when the therapist sees behaviors escalating, sees weight dropping, sees potassium dropping, they may have no choice but to say, I cannot see you anymore in good faith because I can't get a good sense from your doctor for whether you're actually safe or not.
I mean, that's the hardest. I have had to do that, and I hate it, and then really the only alternative is, hey, get an assessment for a higher level of care.
Yeah.
Because that's where you need to go, because nobody else outpatient knows how to do this.
Right. And sometimes that's totally the perfect answer. Sometimes that is life-saving and it's just the best. But I think that there are a number of patient populations that aren't well served by stepping up and then find themselves in a really, really hard situation. For instance, older patients, say above 35, who may have been through res before and frankly don't want to go back and hang out with a bunch of people who feel a lot younger than them, but want to get better and need someone to hold them medically while they continue to progress slowly in their outpatient relationships with their dietitian and their therapist. I think there are some patients who've been to treatment so many times that they could teach the groups, and yet it's only by living within their community and getting the kind of support they need to keep fighting the eating disorder voice to make incremental progress, maybe even towards a harm reduction goal, can their needs actually be met. And so, I'm really passionate about community-based care. When patients have to step up, first of all, medically, I will always encourage them to go to acute because it's still the very best in the country. Mm-hmm. And when patients need and want to step up to res, I know the best programs across the country because I was so lucky to get to know them in detail while I helped to run acute. But there's a lot of people who can successfully remain in their communities. This is done a lot in Europe. And I think that with an experienced internist, The therapist can return to being the therapist, and the dietitian can return to being the dietitian. And the psychiatrist isn't compromised by being asked to prescribe metoclopramide for gastroparesis and what's that new medicine for bone density?
Right.
Instead, we can be a really collaborative team of equals, and we can all give the same message that honors patients' personal goals and values, rather than being assumptive, saying, well, here's what recovery is, and here's where you are, and you're not there yet, so you've got to come to look like this. Instead, I really like a non-assumptive model that says, what do you want? What are your goals? Okay, great. So if that's your goal this week, let's talk about how your eating disorder actions, because nobody dies from thoughts,
Right.
are moving you away or towards that goal. And then you get on the phone with the therapist and the dietitian, and you're all on the same page. And this beautiful human feels held and seen.
Yeah. I mean, I'm just kind of thinking as you're talking here about my clients who I just love dearly and who have had some really negative experiences with their doctors, who I'm sure have the best of intentions. So I guess what would you say to, clients and patients who are out there, outpatient, they're not in a higher level of care right now, and they're listening to this episode and considering maybe I do need to talk to a doctor about this, and maybe I am a little bit concerned about what my eating disorder is doing to my body. What would you say to those people, especially the ones who have maybe been a little bit burned in the past?
Yeah, that's so hard. I would say probably almost every patient with an eating disorder has been burned by doctors. And it sucks. And, part of what I have to do with patients is to name that and say, I bet you're not a really big fan of doctors.
Right.
I bet you don't trust us. And I bet you've been talked down to and had bad care offered unwittingly. And I bet you have very little trust in the medical system. And usually they're like, yep. I think the answer is, please don't give up. If you can't come see me, there are kind doctors out in the community who, even if they don't know anything about eating disorders, if they have the kind of attitude that is, I want to know you as a whole person. I want to understand you in the context of how exquisitely sensitive you are and how things affect you more profoundly than they do almost anyone else you know, and how shameful that can feel, but how that can manifest physically through irritable bowel syndrome, through somatic pain. If you've got someone who can at least be kind, they'll come on the journey with you. And I think it's worthwhile to arm yourself with good data. For instance, the Academy of Eating Disorders just came out with a beautiful new 2016 pamphlet that is freely available on the Academy of Eating Disorders website, which is www.aedweb.org. And I have no financial relationship with AED. And that really gives an overview of good medical care for those with eating disorders. That can be printed out and brought along.
That's wonderful. Thanks for bringing that up.
Yeah, it's a wonderful resource. And I would just say to people, try to keep having faith. There is someone out there who wants to be your doctor and give you a huge hug when she sees you, if that's appropriate, and, take really good care of you as a whole human. And I just apologize for my profession. The fact of the matter is, doctors are almost as anxious as you patients are. And we have terrible stress tolerance and really, really bad abilities to sit with things we can't fix. Mm-hmm. And so unfortunately, doctors use the same coping mechanisms that you may have learned as listeners are not so useful to you. We become rigid, we become dictatorial, we become black and white, and we present things as if they are known, unchanging facts, when in fact we don't know. And, eating disorders can be so difficult to take care of as a patient and as a provider because there's so many unknowns and it's so complicated. And so doctors may just say, I can't deal with this, or you're fine, when what they mean is, it's so hard for me to see you suffering and not be able to influence that.
Yeah. Yeah. I love that. That's so refreshing to hear. What an interesting parallel between how, because of how physicians are trained, how they can kind of mirror how some of our patients present too.
Yeah. And just the personality types that are attracted to being physicians.
Sure.
I often laugh with my patients that, but for some funny fluke of genetics and maybe environment, I have every trait that my eating disorders have. And, I feel so compassionate for those anxious moments and those perfectionistic moments and all of this stuff. I'm like, oh, honey, I am with you. But it's good to be able to model that those can be managed without wrangling your body and being unkind to your food and your nutrition and your physical self. So, yeah.
Oh, absolutely. You're a wonderful model of that for sure. So I'm thinking of when my clients go to their doctors, and one of the major things that they struggle with and then I struggle with and feel really upset and just fired up and passionate about is when they go in, they have their weight taken, whether they see their weight or they do a blind weight where they aren't told, they don't see their weight. And the entire visit becomes about the discussion of their weight. So I was wondering if we could kind of get into weight and wellness and what's the deal with BMI? What do we actually need to care about? So I'm sure we're probably going to talk a while about this. So
yeah, that's a great question. This is something I'm really passionate about. I think, first of all, as someone who has an eating disorder or had an eating disorder, your listeners should be empowered to speak up in their physician's office. And when they come in, whether they're seeing the nurse, the PA, the NP, or the doctor, to say, this is a thing for me. I don't want to discuss my weight with you. I don't want to see my weight. And I don't want you to comment on my body shape or size. Mm-hmm. And that's pretty frontal. I mean, it takes somebody a lot of therapy and a lot of work using their voice to be able to say that. But I think it's a great goal to get to because that sets a baseline. It sets a boundary and an expectation because it really should be all about the patient. So
I still do that. And I still get weight blind.
Good.
Yeah.
Great. I love that.
Because it's not important.
No, because
if something's up, they'll tell me.
That's it. Yeah. Absolutely. I think that it's really important to empower patients who have eating disorders with the knowledge that not all wellness can be measured.
What?
I know. I know. And that can be really hard to understand when that eating disorder voice is saying you're fine. So one of the metaphors I really like using with my patients, and I promise this does have to do with the measurement of wellness, is the house on fire story. And so I might have a patient sitting with me saying, Dr. G, I just worked this unbelievably hard week at work. It was the biggest week in my profession, and I was everywhere. I did a great job. I was amazing. I was praised for it, or at least, I did my best. And yet I was engaging in eating disorder behaviors because I was so stressed. And my eating disorder is telling me, you're fine. See, you can still do it. And what I like to say is the house on fire metaphor. So you imagine that, let's say a young woman is standing outside her burning home, and the fire department comes rushing up and they say, we're here to put out your fire. And she says, what fire? And they say, well, your fire, I can feel the heat. I see the flames. I smell the smoke. And she goes, no. If I had a house fire, it would be so hot that the pavement would be bubbling. And because my sidewalk isn't bubbling, I clearly don't have a house fire. Uh-huh. And so at this point, the fireman goes, you are mentally ill and I'm going to put out your damn fire.
Right.
This is what our patients do. They say, as long as this number is okay, as long as this thing that I do in my life is okay, I must be fine. And P.S., I'm certainly not sick enough to deserve either appropriate care or self-care at home. And what I like to say is that wellness is a whole person concept. I think that the notion of holistic medicine has gotten, often deservedly, a bad rap recently. Because in the classic Western medicine philosophy, and I'll be frank, I am a classic Western medicine doctor, the idea was, here's your diagnosis, take this pill. Unfortunately, some of the complementary strategies have evolved to be, this is your diagnosis, take this supplement. But what an actual holistic perspective does is to say, I see you, both the things I can measure and the things I can only hear about narratively, as a whole person, in the construct of your life, your desires, your stressors, your motivators. And I can put you together, as most of our patients with eating disorders are, from binge eating disorder to ARFID to anorexia to bulimia to all points in between, as being a uniquely sensitive, intelligent person who understands the world and has radar for the world in ways that are wounding for them where it's nothing for other people. And oftentimes, years of that extraordinary sensitivity, often accompanied by a profound need for recharge and for love and for compassion, can yield body symptoms that can't be measured. So the fact is that BMI can be useful in a limited setting to understand what might be going on with somebody medically. But the fact is that there are people with a higher BMI who live in beautifully healthy bodies. And there are people with a higher BMI who live in ill medical bodies, unrelated to an eating disorder. There are people with what's classically known as a normal, and I hate that, BMI,
Me too.
who may be dreadfully sick with an eating disorder, either because they've just lost a tremendous amount of weight or because they're doing behaviors that don't lead to change in weight, but that are desperately bad for them. Or there may be a person at that BMI who's just struggled back from anorexia nervosa, who's in a good place. So, you are not your number. There is no particular perfect weight or BMI. That can be really hard for our patients, right? Because they think, if I'm coming through this, I want to do it right.
Oh,
So
sure.
just tell me what right is, and I'll work on getting there. And it can be so bewildering when I tell them, there's not a right. How about what's the right for you? And it's not a moment in time. It's not a perfect size and shape. It's, what is your body telling us is okay? And that has to be individualized. Some people run a little lighter than what would be their sort of classically expected body weight range.
Right.
And some of those people are really healthy, and some of those people are really not when they're in that weight. Some people need to be curvier than what we consider to be a classically healthy weight range. And that's awesome. I believe deeply in the health at every size movement, or HAZE movement.
I love it. I love it.
Which encourages people to occupy their bodies, to eat for joy and for the enjoyment that social eating and just eating of delicious foods of all varieties in adequate amounts brings to one, to nourish a human form that needs to do tasks and to live and love life. And then to move for joy, not compensatorily, not as a punishment.
Right.
And my deep belief, and it's never going to make any magazine cover, is that if people can do those fundamental things, which is to eat a wide variety of foods in plentiful abundance to fuel your body, and to move for joy, that your body is going to take on a shape and size that was basically written in your genetics.
Yep. So I'm sorry. Let's pause and summarize real quick. So you did undergrad at Harvard, you did med school at University of Boston, and you did your residency at Yale, and then you were the medical director of acute, and you are one of the top doctors in all of eating disorder treatment, and you believe in the health at every size movement.
You bet.
Yay!
Now, I want to be really clear. There are very low body sizes and very high body sizes that are almost certainly not compatible with wellness.
Mm-hmm.
So I don't want anybody, to say every size, but the fact is, outside of those extremes, this gives us a beautiful, luscious bell curve of shapes and sizes and activities that are 100% compatible with health and wellness and a great life, doing all of the things somebody might want to do, from travel and work and sex and, the whole gamut. I love that.
Mm-hmm.
And anything else, trying to do anything else is futile. That's
Right.
the other thing, is that all of these people, fueled by marketing strategies in this country, are constantly being fed a bill of nonsense that says, if only you buy our product, if only you do this thing, you'll all get the exact identical Hollywood standard of thin, white, privileged, cisgendered beauty.
Bring it, Dr. G. Preach. Yeah, I just love everything that you're saying. I'm so excited to hear this because I really do think that it's so refreshing to hear it from a doctor saying that, a physician. Because, I really do think that when you do those things that you mentioned that, HAES and intuitive eating emphasize, which is move joyfully and not because of feeling like you need to compensate or you're not enough, and eat a wide variety of food, eat for pleasure and for health, stop when you're hungry, eat when you're full, or eat when you're hungry, stop when you're full. It's like when you do those things, you do settle in that kind of good spot for wherever your body just wants to be.
That's exactly right. This is what I believe. And it's not just sort of, this is what I believe. This is what I've seen for so many years. And the torment that everybody goes through, feeling like they're inadequate in the shape and size they currently occupy, is needless. And, I love the image of, I'd love to be able to produce this at some point, of a bunch of puppies from all different breeds.
I love this already.
Some are teensy and some are enormous and some have short fur and some have long fur, and just put them side by side in a great big poster and say, what if all of these puppies grew up to torment themselves that they all needed to look like a golden retriever?
Oh.
It would just be silly. We're designed to be different shapes and sizes. And when patients can't get to the point of saying, I love my body, because that's complicated. I mean, loving your body is a wonderful place to be, but a lot of people have too much water under the bridge to love their body, and it puts a lot of pressure on them to love their body.
Yeah.
What I like to say is, don't give the eating disorder an opportunity to jump back in because one day you wake up and you go, boy, not only do I not love my body, but I'm really not a fan of it today, so I'd better do some behaviors. Instead, I like to reduce the pressure and say, be a caretaker of your body.
I love that, actually. Yeah.
We can all be a caretaker of our body. You don't have to love it, and don't use not loving it as an excuse to jump back into or continue with eating disorder behaviors. But just like you would take care of your car or your apartment or your pet, resolve that you'll be a caretaker of your body. And it sort of eases the pressure a little bit.
Oh, definitely. Because I think that standard of radically accepting and loving your body, like, that's wonderful. That's like the unconditional love. Yeah, I would want for everybody to get there. But I don't know if necessarily everybody is. And I also don't think that necessarily everybody has to. Like you said, I really feel like some days the best we can do is tolerate our body or distract and not focus on it, but can we just not be mean to it and try to just be kind toward it?
That feels so right. I'm so glad that you share that perspective with me. I really think can be an important tool to help patients when they hit one of those hurdles.
Yeah, definitely. And also to just, as for our listeners out there who do have eating disorders or are dealing with disordered eating, for you really to take this message and just soak it in, that weight is not wellness. They're not the same thing. And that especially sometimes when you go to your doctor, you really need to kind of hold that in mind. And we have to probably advocate for ourselves more than is a little bit comfortable for, I think, most of us. Because, there are definitely clients of mine who have gone to their doctor because they're having some cold upper respiratory stuff and they're at a higher weight and they're going to get talked to about their weight and they're just going there about their cold. And so I just want for everybody out there to really just hear that from Dr. G, from me. Weight and wellness are really different, and just to kind of embrace that and kind of just soak in that, revel in that idea and take it in for yourself.
Absolutely. And I would add to that, whoever will possibly listen to this, throw away your scale today. It doesn't matter. It's not who you are. It's not a moral measure. Like you just said, Janine, it's not a measure of wellness, because when you get on that scale and you see a number, it may well lead you away from wellness.
Oh, definitely.
Certainly psychological, maybe physical too. No one needs to know their weight. It's a marker of how gravity holds you to the earth. This is not a number you need to keep track of. If you're in recovery, that is, if you're in the process. So I view in recovery as being in the process of getting to a place that you consider recovered. But if you're in recovery and your team needs to do a blind weight, okay, that may help with your meal plan. That may help know how things are going. Taking care of yourself doesn't necessarily become fully intuitive or principally intuitive until you're pretty close to recovered. And it's okay to have some prescriptive stuff in the meantime as you're getting there.
Right.
But I really encourage everyone, throw away your scale.
Yeah. Yeah. Just, you don't need it. I actually think the scale is one of the biggest weights we have. Yeah.
I love that.
Well, in kind of wrapping up for today, one of the things I wanted to ask you is, what are some of your favorite parts of working with patients who have eating disorders who are trying to recover?
Oh my gosh, we don't even have enough time. I love this population so much.
Too.
I love the intelligence. I love the authenticity. I love the anxiety and the fears and the perfectionism and the drivenness. These are extraordinary people whose sensitivity may have been overlooked or not optimally loved since they were toddlers, and they have forged ahead nonetheless, and often done the most remarkable things in their lives, whether artistic or academic, personal, professional, relational. I often feel when I'm taking care of patients with eating disorders, like if I can help them get through this deadly illness and really know and honor themselves, they can go on to have truly happy lives as they define them. And everyone's goals are different, but it's so striking to me that a lot of our patients need to be slowed down because they have so many gifts. And they think, well, if I can do all this, I should do everything. Mm-hmm. And there's so much guilt that comes from being exhausted and overwhelmed by trying to put all of your gifts into play. And as a feminist and the mom of 2 little daughters and as a sister, I love being able to say to my women patients in particular, but often this applies to my men as well, I'm not exactly a slacker. So don't think that I'm all about like, oh, just peace out, whatever.
Right.
But I tell them that you actually can't truly and for the long term tap into your gifts until you make a profound dedication to self-care. And
Wow.
everyone's needs are so different.
Wow.
And I love being able to give that message and tell them there's nothing I don't eat. And I take this body everywhere I go, and I'm joyful in its strength. And, I have to feel the pain of saying no to valuable, worthwhile opportunities in my life and in my profession in order to really live my values and have the energy to give of myself where I choose to. And it's not like that's easy.
Oh my gosh, so
lauded.
hard. Right. Yeah, it's hard when to say no.
Yeah, but in a world of coaches and teachers and parents who were like, you're amazing, do everything perfectly. I really love being the voice of saying, well, do your best on things that matter deeply to you and only do enough for things that are not your top priority, because you've got to learn how to triage your energies. Because you've got a lot to give in this world, but you're also going to be so sensitive and run the risk of burning out and feeling at sea and out of control. So I love being able to give that message, and I just adore my patients.
Yeah. Well, it's so clear just from everything that you said and everything that you've brought up, your passion and your deep caring for people and just your warmth on top of your brilliance medically and otherwise just is so clear.
Thank you.
So, for you being this wonderful top doc in the field who also has self-care and does say no to things, thank you so much for coming on our Eating Disorder Recovery podcast and talking to us about this. It is an absolute honor, and you're welcome to come back anytime and talk with our listeners again.
Janine,
we're so happy to have
amazing.
you.
I'm
thank you.
Grateful for what you do and what you put out into the world. And thank you so much for this opportunity.
Oh, thank you. Thanks for joining me for another episode. Let's keep in touch. You can find all the information you need about the podcast at eatingdisorderrecoverypodcast.com, including full podcast episodes and links to all of our social media sites. You can join our Facebook group for the podcast by searching Eating Disorder Recovery Podcast on Facebook. This is a closed group for listeners of the podcast looking to connect, share resources, and get involved in a pro-recovery community. Don't forget to subscribe to the podcast on iTunes, Stitcher, SoundCloud, or YouTube. Please leave us a review and let us know how we're doing. Talk to you next time on the Eating Disorder Recovery Podcast.